And so what we start to do is really think about, well, what role do I have as a CEO? What role does the senior team? Everybody in these studies, everyone says, oh, the senior team, it's very important to have, set the tone, set the bar, all of that. I said, but what does that look like? She says, well, you're doing it, so why don't you start to write about it and talk about it? So I said, okay, so it actually came down to 4 things. And the 4 things that we now call patient-inspired leadership are 4 things that I carry with me every day. I'm carrying them into my new job, and they are things that I would encourage and challenge each and every one of you. There are 4 things that you can do starting today. So what are those 4 things that I now call patient-inspired leadership? Not patient-centered, but patient-inspired. I like that feeling better. So patient-inspired leadership involves 4 things. The first thing is taking the practice as a leader. Whenever you're looking at reports, how many people have to look at reports? Yeah, it's just mind-numbing sometimes, isn't it? And numbers, we all look at numbers. We were actually getting to a point where we were blind to the meaning of numbers. So after listening, and this is a great example, we had a patient who was at the Hospital Infection Control Committee, because now we include patients everywhere. So after the first question of have you included a patient today, started thinking about those numbers that we're always looking at. And so at a committee meeting, she said, they were putting up charts, 0.08% decrease in hospital-acquired infections, and there's dots and numbers and graphs. And I didn't understand all of them either. But she's there, and she says, so we're talking about hospital-acquired infections, right? Mm-hmm. So how many people came into our hospital last month without an infection and then left with one because we gave them one? That's hospital-acquired infection. So what we decided is we adopted, it was like the aha. So we called that peopleizing the numbers. Peopleizing is not a Canadian word. You can make it an Australian word, but it's just a word that seems to make sense about every number that we started to look at then. And I challenged the leaders, and I challenged myself, and challenged the board. Everything needed to be peopleized. If we were going to work with it, if we were going to care about it, and if we think that number makes a difference on patients and families, then we darn well better peopleize it and know what the heck we're talking about. You know how hard it is to peopleize the numbers? It's really hard. I thought that our data people were going to have a fit. Well, they did. But what we needed to do was translate this. I said, it's like you're speaking another language, and it's not connecting to the people that we need to embrace the so what. And when you start to peopleize and say, there were actually 15 people, 15 families, everybody has a story. 15 people came into our hospital last month without an infection and left with one because we gave it to them. That's hospital-acquired infection. How many people came into our emergency department and waited longer than 12 hours to get up to the unit? Don't talk to me about the 90th percentile. Patient would say, I'm not a 90th percentile. I'm a person who waited and experienced all this stuff while I was in the emergency department for that long period of time. And frankly, not even everybody got out of that situation. So peopleizing the numbers. Leaders can own that. Leaders can take charge of that. Yes, you've got to report a lot of things to the ministry, to everybody, but now we have been crazy about trying to every source we can make, and we're making progress even with the ministry about saying, let's ask the questions differently. Let's ask people to report differently and once people start to work with it and get it, they say, aha. And then, funny thing, people start to make progress on the issues that the numbers are being collected for because it makes sense to them, because they connect with it. We do a whole lot of stuff that doesn't have any value because we've lost the why. So peopleize the numbers. Number one, of patient-inspired leadership. Number two, have you included a patient today? Ask yourself, does this decision I'm about to make have any bearing, any relationship to the experience of patients? And if it does, where's the patient? And you can find them. They're everywhere. They're in your hospital. You don't need to invite them to come on a long drive to your committee. There's many, many creative ways you can involve and engage in meaningful ways. And our patients gave us a gazillion ways we could do this. Have you included a patient today in anything that has a material impact on the experience of patients and families? Third, what have I learned from a patient today? This is a leadership practice that is fundamental to patient and family-centered care, fundamental to creating an environment for patient and family-centered care, fundamental to make the patient experience real. Ask yourself as a leader, what have I learned from a patient today? And if you can't answer that question, you are not spending your time in the right place. What are you here to do? Reframe the way you are, what you're doing in relation to the patient experience. And some of the stuff, the busy work, starts to kind of go, really? Does this make any sense? What have I learned from a patient today? You can do that as a policymaker, as a senior executive, as a frontline nurse, and as anybody within your teams. And then when you learn something from a patient today, what do? Don't just keep that good stuff to yourself. You share the story. So by not only having stories about the patient experience, but what is your experience of what you've learned from a patient today, and you experience that and you run and go and tell someone about what it was like, was it uncomfortable, did it work, did it whatever, then that learning about the patient experience and the value there, it starts to shift and change the conversations that people have with each other. So when I do rounds in the hospital, it was about not what did you do to a patient today, not what you do for a patient, what are all these great things we're doing for patients? I don't ask that question. I say, what do you learn from a patient today? They go, oh my God, well, I'm too busy. Well, no, what'd you learn? Conversation, and then share it. They share it with me, then I might tell someone else.